Hi everyone, today I'll be reviewing a tailored approach article, and that is the Cabrera et al. 2020 article examining an intensive form of TFCBT in an acute adolescent inpatient unit. So before going into some of the key takeaways, I did want to give a brief overview, and that starts with the background and purpose stemming from research showing that a high percentage of hospitalized adolescents have been exposed to traumatic events, and rates of PTSD are higher in this population than the national average. This is combined with an identified need for research examining modified clinical interventions of well-supported treatments to fit this context. So quickly, some things about methodology. That this was an uncontrolled open trial, meaning that participants consisted of patients admitted to a GKL, which was the inpatient unit, a 10-bed program in Sydney, Australia. All participants in the study were enrolled in an intensive TFCBT model of treatment. Some inclusionary criteria was that a primary diagnosis of PTSD was required, and other requirements had to do with length of stay, which I'll talk more about. They also administered pre and post treatment measures. The NSESS is a brief measure of PTSD symptom severity, and the CGAS is a measure of global impairment across domains of skills. Results, they found that treatment led to significant decreases in PTSD symptom severity and improvements in global functioning from pre to post test. So I did want to talk about what the intensive TFCBT intervention looked like. And we're all familiar with TFCBT and the practice components now. And the primary modification was condensing the standard components to meet the average length of stay for adolescents, which was about 22 days. And this meant that sessions occurred over 4 weeks for an average of 2 to 3 sessions per week. Another important thing I mention here about the intervention is that given the novelty of this implementation, fidelity was considered essential. And that's a direct quote from the paper. And it made me think of, what was the level of balance between flexibility and fidelity, which we know is important for individual needs of clients, which wasn't really talked about, but something I just noted. And below that, you'll see the outline of when the practice components were implemented. Caregiver involvement occurred throughout the entirety of the intensive TFCBT, and this was with non-offending caregivers, apart from the sharing of the trauma narrative, which was due to adolescent preference and something that's respected in TFCBT. Patients also received a comprehensive care approach, meaning that researchers didn't control for things like pharmacology, other outside group therapy, or supports like that. Again, this was an open, uncontrolled trial. Some key findings, and I'll start with some information about participants, which were 15 adolescents, which came from a much larger number of individuals who were admitted to the inpatient unit. And this was due to exclusionary criteria around length of stay, primary diagnosis of PTSD. Of the 15 adolescents, most of them were female and experienced a range of trauma exposures, post-traumatic symptomology, and comorbid concerns. The main finding here is that significantly statistic decreases in PTS were observed from pre to post intervention, and significant increases in global functioning were also observed from pre to post in averages of the participant group. Primary implications concern that intervention within inpatient settings can be structured and intensive, opposed to only focusing on containment and stabilization. And when they say structured and intensive, meaning trauma specific and including things like exposure. Is also an implication to incorporate TFCBT specific approaches into larger inpatient systems framework of trauma-informed care. And they also mentioned future directions for research should include studying this with a larger sample size, a control group for comparison, and also conducting follow-up assessments to see if progress or improvements are sustained over time. So I connected this article to outside material and primarily connected it to some of the implications I just mentioned. So Healing Hurt People from the Center for Nonviolence and Social Justice at Drexel University, the two co-creators and directors are pictured to the right, is a trauma-informed hospital-based violence prevention program that serves patients who are recovering from violence or trauma. And the primary goal is to engage these patients when they are most at risk for retaliation of violence and mainly symptoms of trauma. And the program has been shown to reduce PTSD symptomatology. So the main connection there is integrating trauma-specific care into hospital-based settings or adolescent inpatient unit context when they are at risk for developing PTSD or experiencing increases in severity of concerns. And I've also included a link to a YouTube video, which shows a video of the Healing Hurt People program, and I'll make sure to share that in my discussion. That being said, my discussion question is, so the authors state that an implication of this study is that community mental health providers may be able to refer adolescents with PTSD for this intensive TFCBT program within an inpatient setting. So my question is, what factors, personal information, or literature, including this study, would you want to consider when deciding on whether to make such a referral as a hypothetical community mental health provider? And how might the consideration of this information impact your decision to make that referral?